All the lovely doctors, warm welcome to this Fmge recall session for 26th of July 2025. And we had a good number of questions from surgery, and as we were expecting, the paper was moderate. And interestingly, as we have seen at the exam pattern, the paper is becoming more integrated year by year. That means all the basic subjects knowledge is being used in an integrated manner, more so, especially from last 2 to 3 years. So, if we broadly see how many questions were there from surgery, approximately 32 questions were there from surgery. And I hope that all the great doctors who have prepared so well, so nicely, they would have been able to crack a good number of questions from this. Right, so let's take a look. Overall, pediatric surgery was amounting to approximately 2 to 3 questions, adult surgery 10 questions around. Onco surgery this time, we had those 7 to 8 questions, but out of those 7 to 8, 3 were actually core pathology questions where they asked about the gene story. Endocrine was a question there, and then trauma, we had 5 to 6 questions. Vascular surgery, we had 2 questions. Salivary gland, we had 1 question on Fraser syndrome. And then there were questions from miscellaneous topics as well. Right, so Junaid, Christu, Ashwini, Harsh, everybody, lovely, good afternoon, beta. Let's take a look. This is an image-based question, and as we know in the art of solving the image-based questions, first we have to look at the image, then we have to look at the options, then the last line, and then the stem of the question. Right, so here, okay, now if we take a look here, this looks to be a plain X-ray because we are not able to see any contrast here. So if this was the image where there was no contrast, then the answer looks to be clear-cut. Obviously, it cannot be a CT, so it can be a plain X-ray of KUB, it can be IVP, it can be RGP. But because there is no contrast, so definitely this would not be something like this IVP or RGP. So the plain X-ray KUB would have been the right answer here. However, we need to be a little careful and try to understand if suppose in the question, the story was something like this, where the contrast was seen. Like here you can see the contrast on this side as well as on this side. So definitely this would be intravenous pylography or intravenous urography, right? If the image would have been like this, then here you can see there is a catheter which is going into the ureter, and you can see the contrast only on this side. That means this would be a retrograde pylography. Right. Namaste Betaji. So here the correct answer would be plain X-ray KUB if this was the X-ray as we are seeing here. But because these questions are not the exact questions what we actually had in the exam, so depending on what we had in the exam, the answer will definitely change. This is just an effort. These are not the exact questions which were actually asked in the exam. This is just based on the recall. And if we take a look, these are the different contrast studies of the urinary tract, like the IVP, IVU, the retrograde pylography and the antegrade pylography. For the lower urinary tract, if you have to study the bladder, we do a cystogram. If you have to study the urethra, we do a retrograde urethrogram. And micturating cystoureterogram or voiding cystogram is done for 2 pathologies, that is posterior urethral valves and the vesico-ureteric reflux. Right. So if it was IVU, that was really great. Best was number 2. Okay. Okay, beta. So the answer for if this would have been the image, or maybe any image where you were seeing the contrast flowing down, then it would have been IVP or IVU. Right. Now, another image-based question, identify the pathology. If we take a look at this image, definitely here we can see that this would be intravenous urography or intravenous pylography. And in the lower part, we are able to see these two laddus here. So this looks like a cobra head or adder head appearance. And now let's take a look. What were the options here? Bilateral ureterocele, posterior urethral valves, retrocaval ureter, vesico-ureteric reflux. Now, in this particular case, as we can see that there is intramural ureteric dilatation which is seen on both the sides. So in ureterocele, we know that there is partial atresia of the ureteric orifice which causes proximal dilatation leading to this cobra head or adder head appearance. So the best answer here was bilateral ureterocele. In posterior urethral valves, there would have been a MCU which would have been done where we can even see a keyhole sign. Right. In retrocaval ureter, generally we are doing this IVP or IVU, and in a retrocaval ureter we do find a reverse J sign. Reverse J sign. And in vesico-ureteric reflux, we do a MCU, that is micturating cysto-urethrogram, where we can see the reflux of the contrast from the bladder going up in the ureter. Right. So this is the cobra head or the adder head appearance, where we can see the ureterocele. Right. Now another question. This was an interesting question wherein a newborn baby was delivered at community health center with protrusion of abdominal contents through the abdominal wall without any membrane covering the contents. Now, this story, which is saying that there is protrusion of the abdominal contents without any covering, then this would be a case of gastroschisis. And here, what should be the next step in the management of this patient? Now, beta, if there was something like this in the question, like community health center, then the answer can vary. Now, if we imagine that we are posted at community health center, what all facilities will we be getting out there? So let's take a look. Should we cover the protruded abdominal contents with a gauze piece soaked in normal saline and transferred to the neonatal ICUs? Or should we use a silo bag to protect the abdominal contents? Or should we cover the abdominal contents with a bed sheet? Or we should immediately take the baby in the operation theater for immediate surgery to put the protruded abdominal contents back into the abdomen and closure of the abdominal wall? Now, if this was the case, then definitely we cannot take this baby immediately in the operation theater and try to put the abdominal contents back, because already the abdominal cavity would not be having that sufficient area where we can put these abdominal contents, right? So this is going to create more pressure inside the abdomen, which will push the diaphragm and will compromise the lungs. So this is something which should not be done immediately. Now, should we cover the contents with a bed sheet? This also looks to be an absurd answer, because that might be contaminated as well. Now we have to choose whether we should cover the protruded contents with normal saline gauze, or should we use a silo bag to protect the abdominal contents. Now, if this game was not a community health center, but it was a tertiary hospital type of facility where we had the silo bag facility, then yes, we would have used it, because that would have helped in these abdominal contents to go down. But at the community health center, we may not be having the facility of a silo bag. So it is better that we should cover the abdominal contents with a normal saline gauze and then transfer this patient to neonatal ICU center. Right. So for the community health center story, let's say, okay. Now, if we take a look at another question, the art of solving the lengthy questions. Which of the following histological changes is most likely seen in this patient? We have to read the last line of the question first, then we have to look at the options, and then we have to read the stem of the question. Histological changes likely in this patient. This is a 52-year-old man, presents to the outpatient clinic. If we just focus on the options first before reading the question, then this says intestinal columnar epithelium to squamous, gastric foveolar epithelium to squamous, squamous epithelium to intestinal columnar, squamous epithelium to simple cuboidal. Right, so this is a clear cut. Okay, so there was an option with goblet cells. Okay. Right, so I hope in this option they would have mentioned with goblet cells. Now, if you take a look at this question, you all have answered this already. "52-year-old man presents to the outpatient clinic with 7-year history of chronic heartburn and occasional regurgitation, especially after meals, for which he has been taking antacids regularly but without complete relief. He has no history of dysphagia, weight loss, or GI bleed. That means this is something related to acid for which he has been taking the antacids. No dysphagia, that means it's not a case of traffic jam in the esophagus. Upper GI endoscopy suggested Barrett's. Must be, instead of Barrett's, they might have mentioned goblet cells here. So that would be a possibility. And in Barrett's esophagus, we all know the game is the lower esophageal squamous mucosa changes to intestinal columnar lining. So for this, as all the lovely doctors are absolutely correct, Simran, Nikhil, Junaid, Anamika, right. Okay, Ashwini, Wakas, Tanaya, Moni, everybody. Right, beta. Let's take a look. Yeah. Another question. Patient presented with hematomasis, most likely due to esophageal variceal bleed. Which of the following should be the next best step in the management of this patient? Now, if this is the question where a patient is presenting with hematomasis and there is nothing else mentioned in the question whether patient was hemodynamically stable or unstable, right? Then ideally how we approach these patients, any hematomasis patient, we have to see the vitals. If the patient looks stable, fine. If there is any issue in the hemodynamic parameters, for example, suppose because of hematomasis there is huge amount of bleeding, so there will be volume loss in the pipeline, so pressure in the pipeline will go down and oxygen supply to the vital organs will go down. So first of all, we'll focus on saving the life of the patient. That means we'll have to pump in IV fluids, and if there is more than 30% of blood loss, then we also have to pump in RBCs for hemoglobin. We have to pump in platelets, clotting factors as well to stop the bleed. So we'll be focusing on blood transfusion, and we'll be giving tranexamic acid as well to control the bleed. Once the patient becomes stable, then yes, we can go for certain procedures. And if he's saying esophageal variceal bleed, now varices, these are dilated tortuous veins which might be projecting into the lumen of the esophagus. So in those cases, we can simply do endoscopy and we can do rubber band ligation of these varices. So let's see what he has mentioned, because he has not mentioned anything about the hemodynamic stability or instability. And in the options, there is nothing like IV fluids. So yes, Junaid, absolutely correct. Wakas Ahmed, yes, it's leukodepleted blood. Wonderful. Adiba, Foodie, Dushyant, Thiru, Junaid, Mahadev, perfect beta. So the correct answer would be endoscopic variceal ligation. Endoscopic variceal ligation. Right. Okay. Another question. Which of the following treatment would be recommended in a patient who has been suffering from epigastric pain off and on for quite some time, wherein on investigations urea breath test was positive? Now, epigastric pain story, and must be a pathology related to stomach, duodenum, or maybe pancreas. And if he's saying urea breath test positive, then all the great doctors of this country watching the session, they know that this would be positive in this Helicobacter pylori. So this might be a case of maybe a gastritis or maybe peptic ulcer story related to this Helicobacter pylori. And when we have to treat Helicobacter pylori, we have to give eradication therapy, wherein most often we use is triple drug therapy, which is a combination of 2 antibiotics and 1 PPI. In quadruple, which is given for a period of 14 days. In quadruple therapy, we add bismuth subcitrate. We can also use sequential therapy, 5 days some therapy and the next 5 days other therapy, though it was a pharmacology question. But what we use generally here is 2 antibiotics, amoxicillin, clarithromycin, and omeprazole, right? Very good. So all the lovely doctors, absolutely correct, beta. Simran, Thiru, Mohammad, Anamika, Adiba, Piyush, Detroja, very good. Right. So the answer would be amoxiclarithrol and omeprazole. Right. The eradication therapy. Wow. Which of the following is the most likely source of bleeding in case of gastric ulcer? Now, if they're asking the source of bleeding in gastric ulcer, then as per the literature what we have or in the workbook, this gastric ulcer bleed, though it is rare, but if it occurs, it is from the left gastric artery. However, peptic ulcer bleeding is most commonly seen from duodenal ulcers, especially if they are located on the posterior surface of first part of duodenum, and the most common vessel to bleed in duodenal ulcer, it is the gastroduodenal artery, right? So if he's specifically asking about the gastric ulcer, then the best answer would be a left gastric artery, right? Okay. Now, ideally, why they would have asked this question was because generally speaking, if we look at the site of gastric ulcer, it is more often on the lesser curvature in the prepyloric region, and there we focus on the right gastric and the right gastroepiploic. So they should be the reason for this bleeding, but most often the literature says it is from the left gastric artery, gastric ulcer bleeds. Okay. Now, a patient underwent laparoscopic cholecystectomy. 7 days later, she presented to the hospital with pain in the right upper abdomen associated with fever. Ultrasound showed 200 cc of collection in the subhepatic space. What would be the next step in the management of this patient? Now, this is a game of complication of cholecystectomy. If we have done a lap chole, there is a possibility that when the surgeon is actually handling the gallbladder during surgery, there is a possibility, suppose this is the gallbladder, this is the cystic duct, this is the common hepatic, and this is the common bile duct. Now, during laparoscopic surgery, if there were multiple stones here, these stones can slip through the cystic duct and go into the common bile duct. And if these stones go into the common bile duct, they can create a traffic jam type of situation. All the lovely doctors, beta, in this case, we already have removed the gallbladder and we have actually put the clips over the cystic duct. And if I say that there have been stones which might have slipped into the CBD, then all the lovely doctors can imagine that this traffic jam would have caused proximal dilatation, high pressure, and because of this high pressure, these clips can dislodge, and if these clips dislodge, then obviously the bile will start leaking from this area, and there would be bile collection in the subhepatic space. Now beta, if there is a small amount of biliary collection and patient is not having any problems, no discomfort, nothing, then we can simply treat the story by just doing very good Vikas, absolutely correct, बहुत बढ़िया बेटा. So this just need a endobiliary stenting. तो अपन क्या करेंगे, ERCP करके and we'll try to negotiate a stent here. If you put a stent here, then the bile will start flowing through the stent. So there won't be any leak in this area, and this area is going to close spontaneously. ये जो area है ये अपने आप बंद हो जाएगा, right? If it is a small amount of leak, no problems to the patient. Just doing ERCP stenting can sort this problem. But if this is not the case, and suppose there is significant amount of bile leak. Now, if there is significant amount of bile leak, there will in the subhepatic space, because of stasis, infection can occur. And if infection occurs in this localized collection below the liver, then there is a risk that this collection can spread into the peritoneal cavity and can lead to peritonitis septicemia type of story. If this is the case and the patient has come to you when the collection is localized in the subhepatic area, before it causes all that peritonitis and stuff, the first and foremost thing, all the great doctors, they know localized collection of pus anywhere inside the body, we do ultrasound guided catheter drainage, right? Whether we talk about empyema thoracis or we talk about empyema gallbladder, appendicular abscess, pancreatic abscess, breast abscess, ultrasound guided catheter drainage can be done. So in this case, if basically we have to do a ultrasound guided catheter drainage of this collection so that there is no peritonitis. तो अब देखते हैं, this particular patient, he had pain, he had fever, and there was 200 cc collection. So in this, the correct answer will be very good, ultrasound guided catheter drainage, right? Ashwini, main focus will be on percutaneous drainage. Right. Fine. And fortunately, something similar question was there in the workbook itself, right? In the question section. Right. Okay. Beta, because this is a question where I do feel that this is the complications of lap chole is an area which is frequently coming in the exams. So let me explain this in Hindi also for our proud lovely doctor word nature here. So बेटा छोटी सी जो गेम यहाँ पे है, अगर हम लैप कोली कर रहे हैं, सपोज ये गॉल ब्लैडर था, ये सिस्टिक डक्ट थी, ये कॉमन हेपेटिक थी, ये सीबीडी थी, और मान लीजिए गॉल ब्लैडर में बहुत सारे पत्थर थे. जब लैप कोली कर रहे हैं तो सर्जन को नहीं पता चला, वो तो गॉल ब्लैडर को मोबिलाइज कर रहा है. हो सकता है कुछ स्टोन यहाँ स्लिप कर गए और सर्जन ने इसको क्लिप करके गॉल ब्लैडर को निकाल दिया. अब सपोज करो अगर गॉल ब्लैडर को निकाल दिया और बाय चांस सीबीडी के अंदर ऐसा स्टोन रह गया, तो ऑब्वियसली लैप कोली के बाद कॉम्प्लिकेशन में क्या हो सकता है, क्योंकि यहाँ पे ट्रैफिक जैम हो रहा है तो प्रॉक्सिमल कहानी डायलेट होगी, तो इस इलाके में प्रेशर बढ़ेगा. अगर इस इलाके में प्रेशर बढ़ेगा तो इसकी वजह से ये क्लिप्स पे प्रेशर आएगा, उसकी वजह से ये क्लिप यहाँ से डिसलॉज हो जाएगी। अगर ये क्लिप खुल गई बेटा तो जो बाइल था वो यहाँ से लीक करेगा और सब हेपेटिक स्पेस में इकट्ठा होने लगेगा। अगर थोड़ा सा ही बाइल इकट्ठा हो रहा है और पेशेंट को कोई ऐसी तकलीफ नहीं है तो फिर हम इन छोटे से लीक के लिए सिर्फ ईआरसीपी करके अगर स्टेंट को नेगोशिएट कर ले तो इसी से गेम कंट्रोल में आ जाती है। क्योंकि अब क्या होगा, जो बाइल है वो स्टेंट के ल्यूमेन से फ्लो करेगा और वो ड्यूडनम में चला जाएगा, तो कोई भी बाइल यहाँ पे लीक नहीं करेगा। अगर इस रास्ते से कोई नहीं गुजर रहा है तो ये रास्ता अपने आप ही बंद हो जाएगा। तो छोटे मोटे बाइल लीक के लिए तो अपन सिर्फ ईआरसीपी स्टेंटिंग कर सकते हैं, लेकिन अगर मान लो जो बाइल लीक हो रहा है वो छोटा मोटा नहीं है, वो बहुत ज़्यादा बाइल लीक हो रहा है, तो फिर यहाँ पे लोकलाइज कलेक्शन बनेगा और जब भी कहीं भी स्टेसिस होती है तो पार्टी होने के चांसेस होते हैं। और अगर यहाँ पे पार्टी हुई तो खतरा होता है कि ये जो लोकलाइज पार्टी है ये पूरे पेट में फैल सकती है, जिससे पेरिटोनाइटिस हो सकती है। और अगर ये पार्टी ब्लड में चली गई, सेप्टिसीमिया हो गया, तो पूरे शरीर में पार्टी हो सकती है, पेशेंट की जिंदगी जा सकती है। ऐसा होने से पहले इतने बड़े हिंदुस्तान के डॉक्टर्स को कैसे खेलना है? बेसिकली इस लोकलाइज कलेक्शन के लिए हमें अल्ट्रासाउंड में देखते हुए इस कलेक्शन को ड्रेन करना है कैथेटर डाल के, जिससे सारी पार्टी शरीर के बाहर चली जाए और पेशेंट को पेरिटोनाइटिस सेप्टिसीमिया का कोई खतरा नहीं रहे। राइट, सो दैट इज हाउ वी हैव टू प्ले दिस गेम। अच्छा, इसी से रिलेटेड बेटा नीट पीजी जो अभी एग्जाम हुआ, अब जैसे आप आगे बढ़ेंगे तो एक बिलियरी स्ट्रक्चर भी इसका कॉम्प्लिकेशन हो सकता है। तो नीट पीजी में स्ट्रासबर्ग बिस्मथ क्लासिफिकेशन भी पूछ लेते हैं, वो बिलियरी स्ट्रक्चर्स का जो इस बार आया था। राइट, अनदर क्वेश्चन, अ फीमेल पेशेंट presented to the hospital wherein she was diagnosed with an 8 centimeter chylomlymphatic mesenteric cyst. What should be the most appropriate treatment in this patient? तो बेटा अगर काइलोलिम्फेटिक्स, बहुत बढ़िया दिनेश, एब्सोल्युटली करेक्ट। तो दिस वाज अ सिंगल लाइनर क्वेश्चन अगेन, जिसमें इन mesenteric cyst they are seen around 45 years of age, 2 times more common in females, 4 तरह की हो सकती हैं, एंड टिलॉक साइन होता है कि वी कैन मूव द mesenteric cyst in a horizontal direction easily, but vertical movement is not there. Generally, there is a fluctuant, painless abdominal swelling near the umbilicus. Chylomlymphatic and androgynous, because if this question is repeated again, तो यहाँ पे they can ask about enterogenous cyst if it is repeated. गेम क्या है बेटा, दोनों में फ़र्क क्या है? काइलोलिम्फेटिक सिस्ट में इंटेस्टाइन इज नॉट एट ऑल गेटिंग इन्वॉल्व, बट एंटेरोजीनस सिस्ट का नाम ही एंटेरोजीनस। वाई वी आर कॉलिंग दिस एंटेरोजीनस? बिकॉज वन वॉल ऑफ द सिस्ट इज एक्चुअली फॉर्म्ड बाय वन वॉल ऑफ द इंटेस्टाइन। तो बेटा अगर सिस्ट की एक दीवार इंटेस्टाइन बनाएगी तो जब इसको ट्रीट करेंगे enterogenous cyst treatment, we have to remove a segment of the intestine as well, right? But for chylomlymphatic there is no need to remove the intestine. So for chylomlymphatic we are just doing enucleation, for enterogenous we are doing resection and anastomosis. Right, so isme the answer would be enucleation. This will be for enterogenous cyst. Very good, lovely. Right, now another question. This is 28-year-old man, presents with 6-week history of abdominal pain, bloody diarrhea, tenesmus, known diagnosis of ulcerative colitis for the past 3 years. Over the past 3 days, he has developed pain, redness and photophobia in his right eye, HLA-B27 positive, most likely extraintestinal manifestation of this patient. So basically, he is focusing on अल्सरेटिव कोलाइटिस तो हमें ऐसे बड़े क्वेश्चंस में कीवर्ड्स पे फोकस करना है. एज ग्रुप वी नो the Crohn's ulcerative, they are in 20 to 40 years and second peak after 50-60 years of age. Then he's also giving you the ophthalmology symptoms here. Now the extraintestinal manifestations, what we get in both Crohn's and ulcerative, it can affect the joints, which is a polyarthropathy, including ankylosing spondylitis, sacroiliitis. It can affect the eyes, uveitis, scleritis, skin involvement, erythema nodosum and pyoderma gangrenosum. Primary sclerosing cholangitis is commonly seen in ulcerative colitis, where there is more risk of cholangiocarcinoma as well. So if we look at the eye features, then herein uveitis and scleritis, right? So yeah, if we have to focus on the ophthalmology symptoms, then we have to choose between this uveitis, scleritis, because in the question he has mentioned about this ophthalmology symptoms. So a better answer would be BC. Right. So this was there somewhere. Now this is a question where a lot of controversy has been there after the exam, whether it was umbilical hernia or paraumbilical hernia. So what I can say, beta, this image what I am showing, I am just showing because I received some feedback from the students. Some other students said, no, it was not this, it was something else. So you were the best judge to answer this question correctly in the exam, and believe me, all the great doctors, that whatever recalls we are seeing, because the teachers, though they are trying their level best to figure out what would have been asked, but we may not be giving you the exact questions what were actually asked in the exam. This is a fact, this is a truth. So what we need to understand, all of us, because you have attended the exam, you have seen the image with your eyes, and whatever you have seen with your eyes, you would have been the best judge. So it can be an image of umbilical or paraumbilical hernia. Even the best of the best surgeons, many a times, even in clinical practice, are not able to distinguish. So for understanding purpose, we say that in umbilical hernia, it is actually the umbilicus which is popping out like this. As we can see, the umbilicus is popping out, while in paraumbilical hernias, the umbilicus actually dips inside and there is protrusion next to the umbilicus. So umbilicus actually becomes like a C or a crescent. This image what you are seeing, this is incisional hernia image, though it was not there in the exam, but who knows, in the future exam they might give you a hernia like this, and here your eyes should focus that there is a scar which you are seeing here. So if there is herniation through a previous scar, it would be incisional hernia. And also we know that umbilical hernias, why do they occur? Because during intrauterine life, there has to be a facial closure below the umbilicus, but if that does not close properly, then there are chances of umbilical hernia, and most of the times we find these umbilical hernias in small babies. Usually small umbilical hernias, no treatment is required, but if the defect is large, then we have to repair those umbilical hernias. While paraumbilical hernias, they are usually seen in adults, especially obese cirrhotic patients, and there is protrusion around the umbilicus. Apostolus, yes beta, if it was an adult image, then there are chances that it would have been paraumbilical hernia. Right. If we take a look here, another question, 2-year-old boy was brought to the hospital with a painless swelling in the right scrotum associated with redness. The swelling is present since birth and was reducible earlier but now has become irreducible. All the lovely doctors who will be watching this session and who are watching this session right now, because you all also have to appear for the NEET PG exam, this is a common area where the examiner might try to trouble you, right? He creates questions related to different scrotal swellings. For example, if we create a question on hydrocele, and if it is an adult story, then generally you will find that he will be giving you something that there was a scrotal swelling, transillumination was positive, and we can reach on the top of the swelling. Because if the fluid is confined within the scrotum, you can easily reach on the top of the swelling where you can feel that spermatic cord. But all the lovely doctors, if it's a case of hernia, now if suppose the hernia is coming from the inguinal canal down into the scrotum, obviously there would be a scrotal swelling as well, but transillumination will not be positive and you will not be able to reach on top of the swelling because there is a hernia which is coming. So when you try to actually touch the fingers with your thumb on the top of the swelling, in between there would be hernia as well. So you will not be able to touch the thumb and the fingers. So you cannot reach on top of the swelling if it's a case of hernia. This is one story. Another keyword what we need to understand is about varicoceles also. Sometimes varicoceles, they present with dilated tortuous veins in the scrotum, and they can also be reducible because when the patient lies down, the veins which have been tortuous, dilated because of pooling of blood, but as the patient lies down, those veins may empty back into the left renal vein. So that can also be reducible, but when you examine that, it is not a proper swelling, it is the bag of warm feel what you see in varicocele, right? So that is where you have to differentiate. Another important keyword for all the lovely doctors, if they are telling you something about reducibility, irreducibility, right? So your focus should go towards hernia, right? Now here he is talking about a 2-year-old boy. This is brought to the hospital with a painless swelling in the right scrotum, and the swelling is present since birth. It was reducible earlier, but now it has become irreducible. What can be the pathology? Reducible earlier, now irreducible. We all can understand that earlier the swelling was going back into the peridural cavity, now it cannot go back. That means the game would be related to hernia, right? Now, if it's a hernia, so we should think about the hernia option. The confusing words which he has given is redness. Now, if there is redness in the scrotum, that means it can be a case of infection. Even in testicular torsion, we find redness in the scrotum. So, acute epididymoarchitis, yes, it can be there, but then this story should not have been in the question, that there was a swelling which was present since birth. Acute epididymoarchitis would be a short story, 3 to 5 days story, or maybe 2 days story or 1 day story, like that. And he would be giving something like that elevation of the scrotum might relieve pain. That is a positive Prince test in epididymoarchitis. Testicular torsion, generally the age group for testicular torsion, we know that age is just a number but not for the MCQs. So testicular torsion commonly seen between 10 to 25 years of age, right? Now, if it was a testicular torsion, we could have seen this redness in the scrotum, but then there would have been severe pain out of proportion. In fact, in both acute epididymoarchitis and testicular torsion, we would find severe pain. Now, in strangulated hernias, whether it was strangulated hernia or not, herein, just give me a moment. Yeah. Yeah. Cremastic reflex absent, beta, that is in testicular torsion. है ना पल्लवी? ऑर्काइटिस की तरफ डाउट जा रहा है, बट यहाँ पे जो गेम था वो था कि इट इज़ प्रेजेंट सिंस बर्थ, इट वॉज रिड्यूसिबल अर्लियर बट नाउ इट हैज़ बिकम इरिड्यूसिबल। तो पहले अगर अंदर जा सकती थी तो टेस्टिस विल नॉट बी गोइंग इनसाइड, है ना, तो देयर वुड हैव बीन अ कंजेनाइटल हर्निया। In children, we know we can find these congenital hernia hydrocele. Actually, if we look at the intrauterine life, what happens during intrauterine life? If suppose I say this pinky is the peritoneum, then there is actually this peritoneum which is going down into the scrotum. This peritoneum during intrauterine life is going into the scrotum like this, but before birth, the connection of the peritoneal cavity with the scrotum, it obliterates, so that after birth the story is like this. That is why the peritoneal contents cannot go into the scrotum. But if suppose the story is like this after birth, then whatever is there inside the peritoneal cavity, that can easily go into the scrotum. If suppose the intestine omentum is going down, that is congenital hernia, or if fluid in the peritoneal cavity is going down, that will be congenital hydrocele. Whether it is congenital hernia hydrocele, the game is persistence of this process is vaginalis. That is why what we have to do in congenital hernia hydrocele, we have to just open the inguinal canal, put this connection back and close the inguinal canal. That is called as herniotomy. And my dear friends, up to 2 to 3 years of age, this connection can spontaneously get obliterated. No surgery is required up to 2 to 3 years of age generally, right? Okay. So if we look at this question now, it was reducible earlier, but now it has become irreducible. So out of the given options, it is going in favor of hernia. Though if he is writing the term strangulated, then in the question, he should have mentioned pain, right? So out of the given options, strangulated inguinal hernia would be the best answer. 13-year-old boy was brought by the mother to the hospital with complaint of pain in the scrotum within 6 hours. On examination, there was redness, swelling of the scrotum, and cremasteric reflex was absent. Now, what is the most appropriate next step in this boy? Now, this, what I am going to share, beta, this is going to create a controversy in the market, but yes, yeah, so this looks to be a clear-cut case of testicular torsion. The age is going in favor. There is redness, swelling of the scrotum, and a key word which is taking you towards testicular torsion, cremasteric reflex is absent. In testicular torsion, we know there is high-lying testis, thick spermatic cord, absent cremasteric reflex. Now, if this patient has presented within 6 hours, then we should immediately take this patient in the operation theater, do the scrotal exploration, because there is a very high probability of saving this testis if the patient has come within 6 hours. We do the derotation orchidopexy, and simultaneously we have to do a contralateral orchidopexy as well. If the patient has come to us after 24 hours, then it is very difficult to save the testis. And if we cannot save the testis, we have to do orchidectomy and simultaneous contralateral orchidopexy. The controversy will be whether we should go for Doppler or not, right? The consensus, or what Bailey and Love write, is the Doppler is not something which is routinely recommended, because we can get false positive or false results on Doppler. So we should not waste the precious time of this patient where we can save the testis in getting the color Doppler done. If we look at what is written with us in our workbook, this is testicular torsion story. The best would be immediate scrotal exploration. And if the testes are viable, generally if the patient comes to us within 6 hours, they are viable. So we do derotation orchidopexy and contralateral orchidopexy. However, in Bailey and Love, it is clearly mentioned that Doppler, because of false results, we should not waste time in getting the Doppler done. the latest edition, 28th edition of Bailey and Love. So the best answer here would be immediate scrotal exploration. Absolutely correct, Junaid. अगर जल्दी से नहीं किया तो हीरे का कोयला बन सकता है. Very good. Right, Dr. Dinesh. Now, HPV infection is known to be an oncogenic virus with a strong association with certain cancers. Which of the following cancers is most commonly linked to HPV infection? Okay, Apostles, if it was mentioned PHC and option was refer higher center for Doppler, no, not for Doppler. Right. Now let's see. If this HPV story is asked, then all the lovely doctors, we know that HPV is an important culprit for causing cancer, especially near the natural openings of the body. शरीर में जितने भी छेद हैं, उनके बाजू में HPV is a common culprit for cancers. We all know about cervical cancer story, anal cancer story. It is the culprit for penile cancer as well, maybe for distal urethral cancers as well, oral cancers as well, and even esophageal cancers as well. Right. Now let's see. Herein, for esophageal cancer, yes, HPV is a culprit. For stomach cancer, it is not the HPV, which is a usual cause. Oral cancer, yes. Lung cancer, let's leave that. So here, esophageal cancer and oral cancer, both HPV is a culprit. Now, if we have to choose which would be a more appropriate answer out of the two, then just imagine area near the natural opening, right? So oral cancers will be more commonly linked. Yes, Pallavi, for stomach cancer, it is Epstein-Barr virus. Yeah, that is Puneet for stomach cancer. Okay. So out of the two, A and C, oral cancer would be a better answer. Right. Fine. Okay. Now, this is an overlapping question between dermatology, pathology, surgery, and even medicine. 16-year-old boy presents with multiple episodes of abdominal pain, history of passing blood in stools. On examination, he has dark pigmented spots on his lips and the oral mucosa. Endoscopy reveals multiple hematomatous polyps in the small intestine. He could have also written multiple juvenile polyps in the small intestine. So, this condition, answer दिया ही हुआ है. Yes, so this is a clear-cut condition wherein there are multiple juvenile polyps in the intestine associated with melanin pigmentation of the buccal mucosa, hands, forearms. The clear-cut answer is Peutz-Jeghers syndrome. This is their Peutz-Jeghers syndrome. Right. Okay. Now, as we were talking about that in cancers, in oncosurgery this time, they had a lot of questions related to genes. Yes, doctors, hereditary non-polyposis colorectal cancer, also known as Lynch syndrome, is one of the most common inherited colorectal cancer syndromes. It is characterized by early onset colorectal cancer, increased risk of other malignancies. Like we know about the CNS stories, which of the following gene types is most commonly mutated in Lynch syndrome? Absolutely correct, Muskan. So here also the C takes the lead. Right, so it's MMR. Very good. Great. Now, another question. A patient presented with complaint of passage of dark colored stool for the last few days. He has been suffering from epigastric pain for quite some time, for which he has been taking PPIs often. So this might be a case of either gastritis or peptic ulcer story. And they are saying Malina type of thing, dark colored stool. He was diagnosed with a duodenal polyp on investigations. Okay. Which of the following is likely to be elevated in this patient? Right. Perfect. So, Shashti, Ashwani, Tarang, everybody, this should be a case of Zollinger-Ellison syndrome. And as we know, the Zollinger-Ellison syndrome or gastrinoma, this is commonly seen in the gastrinoma triangle. The triangle is bounded superiorly by the junction of cystic duct and the CBD, inferiorly by the junction of second third part of duodenum, and medially by the junction of neck and body of the pancreas. So these tumors can occur anywhere, maybe in the first part of duodenum, second part of duodenum, head of pancreas. And because they will be producing gastrin, this is going to stimulate the parietal cells to produce huge amount of acid, which is going to cause severe GI ulcerations, and patient will present with epigastric pain. So he would be taking that PPIs quite often. So this story would be related to, yes, Pallavi, we do secretin test here, right? Now, another question. This is a 25-year-old man presents with headache, visual disturbance, hypertension. MRI brain shows a cerebellar hemangioblastoma. Abdominal imaging reveals multiple cysts in the kidneys along with a solid renal mass suggestive of renal cell carcinoma. Very young age, renal cell carcinoma. Or this would have been, I think, maybe an older age as well. His father had similar findings and died from a brain tumor in his 40s. Which of the following chromosomal abnormalities is most associated with this condition? So this is the VHL, von Hippel-Lindau syndrome, and this is associated with the short arm of third chromosome. So the correct answer will be deletion of chromosome 3p. Perfect, absolutely correct. In the exam, beta, the options are shuffled, so we cannot just focus on that. Now, another question which was related to medullary thyroid cancer. 40-year-old diagnosed with medullary thyroid cancer during evaluation of a thyroid nodule. Genetic counseling is advised to assess for associated familial syndromes. Which of the following gene mutations most commonly associated? And here, just give me a moment. Right. If we have to choose between them, then red proto-oncogene mutation is commonly associated with this medullary thyroid cancer. Right. It's pathology. Absolutely, it's pathology. Now, a 60-year-old lady presented to the OPD where on clinical examination, she had a hard irregular lump inside the breast with dimpling of the overlying skin. Which of the following can be involved leading to dimpling of skin? So herein, if there is a breast cancer story, and suppose the examiner says there is involvement, there is dimpling of the skin, let us just try to figure out. Suppose now we know that inside the breast there are lactiferous ducts which are converging at the nipple. There are lobules, and to support these duct and lobules there is a connective tissue or the stroma here. If suppose there is a cancer inside the breast, then what is going to happen? In the stroma, we should know that there are suspensory ligaments also, which are actually going from the pectoralis fascia below to the skin above. These are suspensory ligaments, Esley's ligaments or Cooper's ligaments. So these are basically the Cooper's ligaments. Now, if suppose I say there is a Cooper's ligament here and there is a cancer inside the breast, and suppose, because 90% of breast cancers are ductal cancers, and suppose the cancer is growing from this lactiferous duct, and if this cancer, suppose this is the lactiferous duct, the green and the yellow is the cancer. Now, if this cancer involves the Cooper's ligament, then what will happen to the overlying skin? यहाँ पे जो skin है इसका क्या होगा? This skin will be going inside, that is the dimple in the skin or indrawing of the skin. So this dimpling of the skin, what we see, this dimpling is not because the cancer has gone into the skin. Cancer skin में नहीं गया. Cancer is just involving the Cooper's ligaments. But if the examiner gives you a pudgy-orange appearance, orange peel appearance, then the cancer cells would have gone to superficial subdermal lymphatics of the skin. Now, why it is so important for you, the doctors? Because when we do a breast cancer staging, we know 2 to 5, more than 5, any size, chest, skin, both inflammatory. If the cancer is going into the skin, then irrespective of the size of the cancer, the staging of the cancer will change to T4B. That is the reason why the examiners keep on asking questions related to this. So, whether dimple in the skin is T4B or not, answer is no. And in the NEET PG exam on 3rd August, we had a question wherein they asked about pudgy-orange, and in that pudgy-orange question, there were the options given as what is the stage. So A, B, C, D, T4A, T4B, T4C, T4D. Now, if there was no redness mentioned in the question there in the NEET PG, then the answer is T4B. But if there is redness mentioned in the question with pudgy-orange, then the answer becomes T4D. But here, they simply asked what is the reason for indrawing dimpling of the skin? It is involvement of the suspensory ligaments or the Cooper's ligament. Right. So here the answer goes in favor of Cooper's ligaments. Right. So here we can see this dimpling or indrawing of the skin. This is because of involvement of the Cooper's ligament. However, skin involvement in breast cancer like this pudgy-orange type of appearance, according to the staging, if less than 1/3 surface area of the breast is involved and there is no redness, it is T4B. If more than 1/3 surface area of the breast involved and there is redness, then it is T4D. Pudgy-orange is definitely skin involvement. Now, this was a question, though it is looking very simple when we are discussing these questions like this, but maybe on the computer screen, it might have created a little bit of turbulence as well. Now this, what is this? Is it a X-ray, CT, MRI or mammography? Which of the following investigation is shown in the image? Right, so this is a clear-cut mammography story. Right. These are the mammographic images. We know that mammography is not done in young females because young females, the breast is more dense and glandular, but old females, the breast is less dense and glandular. So we might miss the lesions in dense breast. For example, if I try to draw a lesion right in front of you, suppose this is the young breast and this is the old breast. If I create the same lesion in both of them, let's see where we can see them better. Here also you can see, but because of more density of the breast, you are not able to get a better idea about this lesion. While if you see here, you can see the lesion nicely in the old breast. So that is the reason why we avoid doing mammography in young females. So the dictum is less than 40 ultrasound, more than 40 mammography, but high risk cases, we do mammography after 30 years of age. Right. Now, a patient after road traffic accident has been brought to the emergency wherein he is transfused 4 units of packed red blood cells quickly within 1 hour. Which of the following complication is expected in this patient? So this is basically a massive blood transfusion story. Massive blood transfusion story. Right. So if we look at the complications of massive transfusion, massive transfusion is if you are transfusing more than 10 units of packed red blood cells within 24 hours, or you are transfusing more than 4 units of blood transfusion within few hours, maybe within 1 hour only. This is massive. And whenever you are giving massive transfusion, you will be increasing the volume. So there can be congestive cardiac failure in the recipient. Massive transfusions can lead to hyperkalemia as well as hypokalemia. Hyperkalemia because in the stored blood there is lysis of red blood cells, so that more amount of potassium, multiple blood bags going into the recipient, hyperkalemia. Hypokalemia can be because of consumption, especially when we use chelating agents. They can consume or they can chelate with the recipients potassium, calcium, magnesium. That means because of the chelation, we can find hypokalemia, hypocalcemia, hypomagnesemia as well. When we are doing massive transfusions, because we may not be able to adequately warm the blood storage temperature, obviously it will be much less. If we talk about the whole blood, 4 degrees centigrade, and recipient's temperature is 37 degrees centigrade. If you are giving multiple transfusions within short period of time, you may not be able to adequately warm those blood, which can lead to hypothermia in the recipient. Also, in stored blood, because the viability of the platelets, clotting factors, everything will be going down. So less viable platelets, clotting factors will be going in the recipient. Already this patient whom you are giving massive transfusion, you would be giving lots and lots of IV fluids like normal saline and all. Patient has already lost his own platelets and clotting factors, and whatever blood you are transfusing, that may also not be having sufficient platelets and clotting factors. So there can be thrombocytopenia in the recipient and disseminated intravascular coagulopathy. Coagulation failure can occur. So apart from this, the stored blood pH is 6.3, so you can find metabolic acidosis in massive transfusions. So these can be the different complications in massive transfusion. Now let's see which of the following complication is expected in this patient. Hyperthermia, no, we find hypothermia. Hypocalcemia, yes, we can find hypocalcemia. Sodium story, no. Right, so in the given question, the correct answer will be hypocalcemia. Right. So generally, these are the complications what we see. This is what is mentioned in the standard textbook Bailey and Love. There can be coagulopathy, hypocalcemia, hyperkalemia, hypokalemia, and hypothermia. Right. An adult patient was brought to the emergency following a road traffic accident with breathing difficulty. Okay, so there is a road traffic accident with breathing difficulty. On auscultation, breath sounds were absent on one side and there was mediastinal shift. What would be the next step in the management of this patient? Okay, so if we try to focus on all the lovely doctors, they know that God has given us two air balloons, and suppose there is any collection on one side, maybe air or maybe blood or fluid, whatever is the collection. What can happen? Obviously, if it is fluid, it will be settling more towards the bases, blood will be settling more towards the bases, air will be settling more towards the upper area. Now, if this is the case, whenever there is any collection in the pleural cavity, whether it is pneumothorax or hydrothorax or hemothorax, this is going to put pressure on the ipsilateral lung, because of which patient can have some difficulty in breathing or dyspnea. Now, if only one lung is under pressure, then what happens, beta? When the oxygen is going in, agreed that oxygen may not be able to go nicely on this side, but definitely it will be going nicely on this side, and we know there is a pipeline, so the blood, this oxygen will be diffusing nicely into the pipeline on this side. And if there is sufficient pressure in the pipeline, then sufficient oxygen will be going to the vital organs. That means this patient is not going to die. Right? In these cases, when patient looks to be stable, what we want to achieve is, we want that this lung should expand. And if you have to expand this lung, then you have to put a intercostal tube drain. This intercostal tube drain is put in the 4th or 5th intercostal space, just anterior to the mid-axillary line, along the upper border of the lower rib. And this is connected to an underwater seal bag. Once you drain all the collection, beta, whether it is pneumo, hydro, hemo, then you will create a space. You encourage the patient for breathing exercise so that the lung can expand and the story becomes normal. Right? This is a pneumothorax story or hydrothorax or hemothorax story. Now, if I say that there is huge amount of collection, now if there is a huge amount of collection which is not only causing compression of the ipsilateral lung, but it is also causing mediastinal shift. That means the opposite lung has also come under pressure. And beta, if opposite lung has also come under pressure, then what is going to happen? Then the oxygen will not be able to go into the pipeline. So if the oxygen is not going into the pipeline, then even if there is sufficient pressure in the pipeline, oxygen is not going to the vital organs and this patient will die quickly. In these cases, we do not have time to put the intercostal tube. We have to immediately put a wide bore needle. Just put a wide bore needle in the same space. Or in case of children, we can put this wide bore needle in the 2nd intercostal space in the mid-clavicular line. Try to decompress this system. Try to release some pressure from this lung. If you can release some pressure from this lung, then the oxygen will be going into the pipeline and you can save the life of this patient, maybe at least for 10, 15, 20 minutes. So if you are able to save this patient even for 15, 20 minutes or so, then you will get the time to put the intercostal tube and then you can just drain all this collection and advise breathing exercises and the life and everything will be saved. I repeat this in Hindi also, beta, because this is an area which is commonly focused by the examiners because they want to extract this concept from the great doctors. मुद्दे की बात सिर्फ इतनी सी है बेटा कि हमें ये देखना है कि एक तरफ का गुब्बारा कोलैप्स्ड है कि दोनों गुब्बारे कोलैप्स्ड हैं. कोई भी एक्सीडेंट हो या कुछ भी ऐसी कहानी हो जिसमें प्लूरल कैविटी में चाहे हवा भरे, पानी भरे, ब्लड भरे, अगर दबाव एक ही गुब्बारे पे है तो इसका मतलब दूसरा गुब्बारा नॉर्मल है, जो ऑक्सीजन आ रही है ये दूसरे गुब्बारे से पाइपलाइन में जाएगी और अगर पाइपलाइन में सफिशिएंट प्रेशर है तो ये ऑक्सीजन वाइटल ऑर्गन्स को जाएगी. ये पेशेंट मरने नहीं वाला भी. पेशेंट इज स्टेबल बिकॉज ऑक्सीजन इज गोइंग टू द वाइटल ऑर्गन्स. दैट मीन्स ऐसे स्टेबल पेशेंट्स में वी हैव गॉट सफिशिएंट टाइम टू पुट द इंटरकॉस्टल ट्यूब एक ट्यूब डाल दी जाएगी 4th 5th इंटरकॉस्टल स्पेस जस्ट एंटीरियर टू मिड एक्सरेड लाइन अलोंग द अपर बॉर्डर ऑफ द लोअर लिप। यहाँ जो भी सामान भरा था उसको ड्रेन करेंगे। जो ट्यूब है वो एक अंडर वाटर सील बैग में कनेक्ट करते हैं। जब ये सामान ड्रेन हो जाएगा, स्पेस क्रिएट हो जाएगी, तो ब्रीदिंग एक्सरसाइजेज एडवाइस कर देंगे और ये गुब्बारा एक्सपेंड हो जाएगा। लेकिन अगर गेम ऐसी है कि बहुत सारी हवा अचानक से भर रही है, अगर बहुत सारी हवा भरने लगी है जिसकी वजह से मीडाइस्टेनल शिफ्ट होने लगा है, तो इसका मतलब जो दूसरा गुब्बारा है वो भी दबाव में आ गया है। अगर दूसरा गुब्बारा भी दब गया है तो ऑक्सीजन पाइपलाइन में नहीं जा रही है, और अगर ऑक्सीजन पाइपलाइन में नहीं जा रही है तो वाइटल ऑर्गन्स को नहीं जा रही है। इसका मतलब इस पेशेंट की मृत्यु होने वाली है। यू आर द सेकेंड गॉड, आप दूसरे भगवान हैं, आप इसकी जिंदगी नहीं जाने दे सकते। जिंदगी बचाने के लिए इमीडिएटली क्या करना है? हमारे पास इतना वक्त नहीं है कि हम इसमें ट्यूब डाल सकें, लेकिन हाँ, एक सुई तो डाली जा सकती है। You will immediately put a tube and you will immediately put a needle and try to decompress this. Try to decrease the pressure on the lung. अगर दूसरे गुब्बारे से थोड़ा दबाव कम करेंगे तो ऑक्सीजन दूसरे गुब्बारे से पाइपलाइन में चली जाएगी, वाइटल ऑर्गन्स को चली जाएगी, और चाहे कुछ मिनटों के लिए सही, लेकिन आप इसकी जिंदगी तो बचा पाएंगे। अगर आपके पास 10, 15, 20 मिनट भी मिल गए तो सफिशिएंट टाइम होगा, फिर आप इसमें ट्यूब डाल सकते हैं। और जैसे ही इसमें ट्यूब डलेगी वैसे ही ये सामान ड्रेन हो जाएगा और फिर ब्रीदिंग एक्सरसाइज करा के गुब्बारों को फुलवा देंगे। तो कॉन्सेप्ट जो पूछा जाता है वो इस बात पे पूछा जाता है कि भैया एक गुब्बारा फुस है कि दोनों गुब्बारे फुस हैं, वेदर ओनली वन लंग इज अंडर प्रेशर और बोथ द लंग्स आर अंडर प्रेशर। रिमेंबर ऑल द ग्रेट डॉक्टर्स फॉर योर फ्यूचर एग्जाम्स ऑल्सो कि इफ ओनली वन लंग इज अंडर प्रेशर you can put the tube, but if both the lungs are under pressure you have to put the needle. Right, now let's see. An adult patient was brought to the emergency following road traffic accident with breathing difficulty. On auscultation, breath sounds were absent on one side and there was mediastinal shift. सिर्फ इस शब्द से गेम पलट जाएगी. The game will change because of this mediastinal shift. What would be the next step? Tube or needle? Answer will be needle. Now this needle insertion will be ideally, in case of adults, this is put in the 4th or 5th intercostal space just anterior to the mid-axillary line. In children we put it in 2nd intercostal space in the mid-clavicular line, but earlier we used to put this needle. This is what we are saying is according to the ATLS guideline. But earlier we were putting this needle in the 2nd intercostal space in the mid-clavicular line only. So मुद्दा ये नहीं है कि दूसरी में डालेंगे कि चौथी पांचवी में डालेंगे. The game is whether you will be putting a needle or you will be putting a tube. So obviously beta, all the lovely doctors, you have mentioned it absolutely correctly. You will be putting a needle. Right. Okay. So this is a tension pneumothorax story where we are doing an immediate needle thoracocentesis with a 14 gauge needle. Right. A patient was brought to the emergency following a stab injury with a penetrating wound in the abdomen. मतलब ये abdomen था या chest था, I'm not sure about it. अगर किसी ने पेट में चाकू मारा है, patient vital parameters are stable. What should be the next step in the management of this patient? So in abdominal traumas, if we talk about any abdominal trauma, if the patient is stable, that means there is no major vascular injury. So the pressure in the pipeline will be normal, oxygen supply to the vital organs would be normal. There is hardly anything where we have to pump in IV fluids, we have to generate pressure in the pipeline or something like that. That means if the patient is stable, the first thing what we do in these situations is EFAST, that is extended focused assessment by sonography in trauma, where we scan the important areas like in the abdomen, we scan the epigastrium for the pericardial cavity, the right hypochondrium for liver and right kidney, left hypochondrium for spleen, left kidney, and pelvic area for any free fluid in the peritoneal cavity. Along with the abdomen, we extend it in the thorax And we do scanning for both the pleural cavities for bilateral pleural collections as well. So it is not fast, it is E-fast. If on E-fast we find there is some problem, maybe in the liver, spleen, kidney or anywhere, then we do a CECT. Better than ultrasound would be CCT, but remember this, we are talking about a hemodynamically stable patient. And generally the treatment in these patients is conservative. But if suppose there is a major injury to liver, spleen or kidney which is bleeding profusely, अगर किसी का एक्सीडेंट हुआ या किसी ने किसी के पेट में चाकू मारा है और मान लो लिवर में खतरनाक इंजरी है और ये खुल के ब्लीड कर रहा है, any major bleeding beta, the volume in the pipeline will go down, pressure in the pipeline will go down, oxygen supply to the vital organs will go down, and this patient can die. In this patient, you will try to save the life of this patient. You have to generate pressure in the pipeline, so you will be pumping in IV fluids. We follow the standard guidelines of A, B, C, D, E. A for airway, B breathing, C circulation, D disability, E exposure. तो अगर पेशेंट अनस्टेबल है तो पहले उसकी जिंदगी बचानी है, A, B, C, D, E. If the patient is becoming a bit stable and while you are doing this A, B, C, D, E, if you have got the facility of E-fast in the emergency, quickly somebody can do this E-fast and tell you what is the area which looks to be more injured. There is no role of CT scan or CECT in an unstable patient, because unstable patient who is already having less oxygen supply to the vital organs is going to die quickly. If you send this patient for CT scan, you are wasting his precious time. You have to first stabilize the patient. If despite pumping in IV fluids, blood, Trenexa, the pressure in the pipeline is not coming up, that means there is a major bleed going inside. You cannot wait. Take this patient immediately in the operation theater, open that area and apply direct pressure to stop the bleed. The best method to control bleeding is direct pressure. And that is how we save the life of these patients. So this patient looks to be stable. Next step, they are asking, should we do a X-ray? Should we do a CCT? We can do a CCT, but before CCT, we'll prefer getting a E-fast if that is there in the option. Obviously, this patient may not be requiring any laparotomy. So here the correct answer will be E-fast. Right. Like here, there was a question. Okay. A patient was admitted in the burn ward of the hospital with 30% burns, wherein he was resuscitated with the fluid calculated as per the Parkland formula. After 6 hours of fluid resuscitation, he was still having cool extremities with a blood pressure of 90/60. His 30% burns, resuscitated as per Parkland, after 6 hours of fluid, still having cool extremities, BP 90/60, urine output less. Okay, that means whatever fluid you are giving to this patient, that fluid was less. That is why pressure in the pipeline is not coming up. And we know whenever any situation, whether it's a bleeding situation or a hypovolemia situation like we see in burn patient, or maybe vomiting, diarrhea, dehydration type of situation, whenever the volume in the pipeline is going down, pressure in the pipeline is going down, oxygen supply to the vital organs is going down, patient can die. You have to generate pressure in the pipeline. And you have to pump in IV fluids like in general, we are giving normal saline, normal saline, normal saline. In burn patients, we are giving ringalactate, and a solution very close to ringalactate is Hartmann's solution. So we can use the ringalactate or the Hartmann's solution in burn patients. How do we monitor that whatever fluid we are giving, that is sufficient or not? That is by urine output. If the urine output is less, we have to give more fluid. If the urine output is more, we have to decrease the fluid infusion. Now, what should be the next step? Even after 6 hours, if the urine output is less, you have to increase the fluid infusion. Right. So wait for 2 more hours and continue the ongoing treatment. Why to wait for 2 more hours if the urine output is less? Switch from crystalloid to colloid. Generally, we avoid giving colloids in the first 24 hours, especially in those times when the vessels are leaky. Because by chance, if we are giving a colloid solution, suppose I say that this is the pipeline, and suppose there is a fluid loss from this pipeline, and because of this fluid loss, the volume in the pipeline is going down, pressure in the pipeline is going down. So we have to pump in IV fluids and generate pressure in the pipeline. And we have got two options, crystalloid option and colloid option. Now, colloid is something which has got protein. Like your blood is a colloid, plasma proteins. If we are giving a colloid solution, then what is going to happen? This colloid will be going in the pipeline. Suppose I use this color, colloid is going in the pipeline. This colloid is going here, will try to increase the pressure, but this colloid will also be leaking out. And if the colloid is leaking out, that means if the protein is leaking out, it will exert the oncotic pressure and will drag more intravascular fluid to the extravascular space. That means it may not be able to increase that much pressure in the pipeline which a crystalloid can do. If we are using a crystalloid solution, then yes, crystalloid does not have any protein. So now what is going to happen? There is no protein which will be leaking out. Suppose you are giving a crystalloid solution, crystalloid will be leaking out, crystalloid will be going here, but because no protein is leaking out, no extra oncotic pressure to remove intravascular fluid to extravascular space. That means you will be able to generate better pressure in the pipeline if you are giving a crystalloid. So we prefer using crystalloid. That means we are not going to switch from crystalloid to colloid. It is just 6 hours story. Colloids can be considered after 24 hours. Give additional bolus of Hartmann solution. Yes, we should increase the fluid. Consider referral of this patient to higher center. Now, because you have to make the patient stable before you refer this patient to the higher center, otherwise the patient can die on the way. So a better option is here, you have to just increase the volume of fluid. Right. Akhil, it can be any time, maybe tomorrow or maybe on 10th, somewhere. Right. So we have to monitor the fluid resuscitation by urine output. If the urine output is less, we have to increase the fluid. If the urine output is more, we have to decrease the fluid. Patient suffered from 40% of third-degree burns over the arm, following which he was treated in the hospital where split-thickness skin grafting surgery was done. He developed stiffness at the graft site in 7 to 10 days. Which of the following next step would you recommend to this patient? Now, whenever we are doing skin grafting, then it takes approximately 5 days for the skin graft to settle at the recipient site. Whether we should recommend physiotherapy or not. We should ideally start physiotherapy on day 1 to avoid post-burn contractures, but in case of skin grafting, we start this physiotherapy after 5 days. And physiotherapy in skin grafting is started after 5 days, right? And this time there was a question in NEET PG exam where they showed something like this. Now, if it was just the cutting of the skin related to a burn patient, it was escharotomy. But if it was something related to cutting of the skin subcutaneous tissue and the fascia, then it would have been fasciotomy. The first impressions, it might be a escharotomy, what they have mentioned, because eschar can act as a tourniquet and compromise the blood supply to the distal part. Anyways, coming back to this, if stiffness is developing at the graft site, that means physiotherapy is not being properly done. So we have to encourage the patient to do a proper physiotherapy, maybe under supervision. Should we stop physiotherapy? No. Graft would have already been settled by this time. Take the patient for surgery for release of contracture. Contracture is going to take a long time to develop. Should we remove the graft? No. Should we mobilize and start physiotherapy under supervision? Right, Padmini, absolutely correct. So we should mobilize and start physiotherapy under supervision. Okay. Which of the following structure is involved in the pathology as shown in the image given below? Now, if we look at this image, this looks to be a dilated tortuous vein. And if we look at the venous anatomy in the lower limb, there is a dorsal venous arch here. The medial part, this becomes the great saphenous vein. It's starting around the medial malleolus, and this is ascending up on the medial side of the leg, going up and opening in the femoral vein just below the groin crease. So this is the great saphenous vein or the long saphenous vein. If they ask you something on the lateral side, it would be the short saphenous vein, which is opening in the popliteal vein, in the popliteal fossa. So the lateral part, there will be short saphenous vein. And we know there are perforators maybe above the ankle, below the knee, and in mid-thigh as well. Right. Generally, in varicose veins, the commonest valve which is getting damaged is the saphenofemoral valve. And if the saphenofemoral valve gets damaged, then when the person is walking, muscles are contracting, more pressure in the deep vein, so blood is moving towards the heart, plus blood starts coming through that weak saphenofemoral valve into the long saphenous vein, because of which this long saphenous vein becomes abnormally dilated and tortuous. So on the medial side, this is the short saphenous vein. Right. This is the short saphenous vein. Oh, sorry, this is the long saphenous vein. Sorry. So here the answer is the great saphenous vein or the long saphenous vein on the medial side. Short saphenous vein is on the lateral side. Right. Which is the likely pathology in the image given below? Now, this is a ulcer which is around the medial malleolus, and this is a venous ulcer, for a simple reason that if we look at this varicose vein, the commonest vein involved in varicose vein is the long saphenous vein. If there is more amount of blood pooling in the long saphenous vein, all the lovely doctors can see that this would be the most dependent area of the long saphenous vein. So maximum pooling of blood will be in the lower part in the long saphenous vein around the medial malleolus. Because of huge amount of pooling of blood around the medial malleolus, this can put pressure on the overlying skin, and the overlying skin will ulcerate. That is why most commonly we find venous ulcers around the medial malleolus. However, if we find an ulcer on the dorsum aspect of the foot, then it is most likely an arterial ulcer. And if we find the ulcers on the pressure points, then it would be a trophic ulcer. So with the location, we can figure out whether it is arterial, venous, or the trophic or pressure ulcers. So here the answer is venous ulcer. Right. And here we can see ulcer at the tip of the toes or the dorsum of the foot, it is arterial. Ulcer around the medial malleolus, this is venous. And ulcer at the pressure points like heel sole, this is trophic ulcer. Right. And these are the images, the arterial, the venous, and the trophic ulcers or the pressure source. Right. 45-year-old woman presents to the OPD with a peculiar complaint. She underwent a parotid gland surgery 8 months ago for a benign tumor. We know the commonest benign tumor in the parotid is a pleomorphic adenoma. Which of the following is the likely complication of this surgery? Fraze syndrome. So Fraze syndrome, we all know when we are doing a superficial parotidectomy, now there may be inappropriate regeneration of parasympathetic nerve fibers from the auriculotemporal nerve into the skin of the parotid bed, so that sometimes after surgery, when the patient is having a taste of something, or maybe he's taking a meal, Because of parasympathetic stimulation, there can be sweating and erythema in this parotid region. And this sweating and erythema in the parotid region is gustatory sweating or auriculotemporal syndrome or Fraze syndrome. We can confirm it by starch iodide test. We can prevent it by putting some barrier between the skin and the parotid bed. Like we can take the sternomastoid muscle, we can take temporalis fascia or put some artificial membranes. But if the patient has developed Fraze syndrome, then we give botulinum toxins or maybe advise the patient to use antiperspirants. Like if we see sweating and erythema in the parotid region on smell or taste of food, this is what is Fraze syndrome. Now, in this, let's see. Okay. So whether it was pain due to preauricular nerve on smell or taste of food, pain, no, it should be sweating erythema. Sweating and redness at the preauricular region on smell or taste of food, yes. Loss of sensation in the postauricular or facial nerve palsy causing gustatory lacrimation. The best answer here will be sweating and redness at the preauricular region on smell or taste of food. Absolutely correct, Yashwant Singh. Dr. Debeki, yes, it's the auriculotemporal nerve. Acha, only Fraze syndrome written. So this was a single liner story. Right. Okay. Left. Now there were some questions which were actually overlapping questions between different subjects. Like there was a question related to left hemihepatectomy involved removal of which of the following segments of liver. So if you are going to remove left side of the liver, if we take a look at the anatomy, the different segments of the liver, we know the segment 1 would be the quadrate lobe here. Then on the left side, this is the segment 2, this is the segment 3, and this is the segment 4. And then in the right side, this is the segment 5, segment 6, segment 7, and segment 8. So when we are saying left hemihepatectomy, we are actually taking out the second, third, and fourth segment. Now, these are different stories shown here. For example, the blue colored thing, if we focus just on the blue shaded area, 5, 6, 7, 8 removal, this is right hepatectomy. 2, 3, 4 removal is left hepatectomy. Extended right will be when along with 5, 6, 7, 8, we also remove 4, that is the extended right hepatectomy. And if along with 2, 3, 4, we also remove 5 and 8, that is extended left hepatectomy. So this time they asked about the left hepatectomy basically. They can ask us about right hepatectomy or maybe extended left, extended right hepatectomy. We just need to remember the segments of liver nicely. The segment 1 is below, which we are not touching in any of the hepatectomies. Basically, in right hepatectomies, we are removing 5, 6, 7, 8. Extended right, along with 5, 6, 7, 8, we are also removing 4. While left hepatectomies, we are removing 2, 3, and 4. And extended left, we are removing 2, 3, 4, 5, and 8. Right. So if he asked about left side, then the answer would be 2, 3, and 4. Yes. Which of the following is true about damage control surgery? Now, damage control is something when the patient would be in a very serious condition. Suppose the patient has suffered a road traffic accident where there might be significant injury to liver, spleen, kidney, or suppose the abdominal wall is opened up and we are seeing the intestines and all. We know that there are very high chances that this patient is going to die quickly. Now in these patients, if we try to do any heroic surgery or something early on, then patient may not be able to tolerate those major surgeries or major duration surgeries. So we try to first control the damage, then stabilize the patient, and then do the definitive surgeries. That means if we look at what are the phases of damage control surgery, then phase 1 is the initial phase where we focus on stopping the bleeding and contamination. This includes ligation or packing of bleeding vessels, or stapled bowel resections without anastomosis, or temporary abdominal closure just using a vacuum dressing or maybe Bogota bag. Phase 2 is resuscitation in the ICU, correct the physiological changes what has occurred, like warming the patient, correct the acidosis, coagulopathy, hypovolemia, monitor the blood reports, and support the ventilation. Once the patient is stabilized, then the phase 3 is definitive surgery, where you can repair the injuries permanently. Whatever packs you would have put in the phase 1, now you can remove. Whatever bowel resections you have done, now you can do the anastomosis and you can close the abdomen definitely. If we take a look at this story, what is the sequence they are asking? ICU resuscitation, identify the patient, closure of the abdomen, control of hemorrhage. So herein definitely identification of the patient is must. So second should come first. And we have got two options where second is first. Then comes control of bleeding. Right. So we should control the bleed. That means next will be fourth. Now in these two, this looks to be a better answer. Now do the resuscitation in the ICU and then do a definitive closure. Right. Fine. So the correct answer here is identify the patient first, control the bleeding, then resuscitate in ICU, and then do definitive closure. Now, first time in the history of FMG exam, we had questions related to the sutures or something, wherein they asked basically what is this particular suture here, or I think they gave the image. There was an image like this, and plus there was another image as well. Let me just check. Okay. There was an image not like this, but something similar to this. Now they were asking what is the type of suture, and in the options they gave the options as whether it was a vertical mattress suture, or it was a horizontal mattress, or simple interrupted, or simple continuous suture. This topic of sutures and the knots, this has been more relevant in the NEET PG. First time in almost 23-year history, they are asking these suturing techniques in the FMG exam. Now here you have to just focus on these are simple interrupted sutures. You are seeing the knot on the one side and you are seeing a thread completely. This is simple interrupted. Now if you look at this, okay, Dr. Debicki, herein, now this is a simple continuous suture. Continuous matlab, we took the first bite and then we are just continuing it. We are not knotting it. So we are moving the suture like this. And now in the end, we are putting the knot. So you can see in continuous suture, what you are able to see, it is not the horizontal game. ऐसी गेम नहीं है, oblique गेम दिखाई दे रही है, राइट? क्योंकि ये जो डॉट डॉट है ये तो एक्सप्लेनेशन के लिए बना है, लेकिन वैसे हम देखें तो ये डॉटेड लाइन नहीं दिखेगी, तो हमें ये ऐसे ऑब्लिक थ्रेड दिखाई देंगे. सो दैट इज अ कंटिन्यूअस सूचर एंड यू आर नॉट सीइंग एनी नॉट एनीवेयर. यहाँ पे कहीं बीच में नॉट नहीं दिख रही है. सो इट इज जस्ट अ कंटिन्यूअस सूचर, सिंपल कंटिन्यूअस सूचर. अच्छा, अब दिस इज अ सिंपल कंटिन्यूअस इंटरलॉकिंग सूचर. तो है तो ये भी कंटिन्यूस सूचर बिकॉज यू आर नॉट सीइंग एनी नॉट इन बिटवीन, बट व्हाट यू कैन सी देयर इज अनदर स्टोरी विच यू कैन सी ऑन दिस साइड. You are actually locking the suture. So this is interlocking, simple continuous interlocking suturing. Now if we look at this, this is a vertical and horizontal mattress suture. अब यहाँ पे बेटा बस ये ध्यान रखना कि अपने को जो बीच की लाइन है उसमें कोई सूचर नहीं दिख रहा है. वी आर नॉट एबल टू सी एनी सूचर इन बिटवीन. उल्टा है यहाँ पे. वर्टिकल में आइडियली होना कैसे चाहिए था, ऐसे वर्टिकल होना चाहिए था, लेकिन वर्टिकल में दिखाई कैसा दे रहा है, ऐसा दे रहा है. ठीक है. हॉरिजॉन्टल में कैसा होना चाहिए था, दिखना ऐसा चाहिए था, लेकिन हॉरिजॉन्टल में दिख कैसा रहा है, वर्टिकल दिख रहा है. तो इफ इट इज अ हॉरिजॉन्टल और बीच में ये गैप दिखाई दे रहा है और साथ में यू आर सीइंग द नॉट्स एवरीवेयर, राइट. तो दिस इज अ वर्टिकल मैट्रेस एंड दिस इज अ हॉरिजॉन्टल मैट्रेस. तो हॉरिजॉन्टल वाला और सिंपल इंटरप्टेड. नाउ यहां पे इफ यू केयरफुली सी बेटा, तो इन दोनों के बीच में गैप दिखाई दे रहा है, राइट. इन दोनों के बीच में गैप दिखाई दे रहा है. यू आर एबल टू सी द गैप बिटवीन दीज टू सूचर्स. जबकि कंटिन्यूअस में क्या होगा, सी कंटिन्यूअस में अपने को ऑब्लिक स्ट्रिंग्स दिखाई दे रहे हैं. सिंपल इंटरप्टेड, यू आर आस्किंग सिंपल इंटरप्टेड. ओके, सिंपल इंटरप्टेड. देखो बेटा इसमें तो इजी है क्योंकि बीच में भी आपको ये थ्रेड दिख रहा है ना, यू आर एबल टू सी द थ्रेड. पूरे में थ्रेड दिख रहा है, पूरे में धागा दिख रहा है. ये सिंपल सूचर है. अपन ने एक बाइट यहाँ से ली, फिर यहाँ से आए और फिर नॉटिंग कर दी, तो पूरे में वी आर एबल टू सी द थ्रेड. लेकिन जो ये सूचर है, वर्टिकल मैट्रेस यू आर टॉकिंग अबाउट, तो इसमें अपने को पूरे में सूचर नहीं दिख रहा है. यू आर एबल टू सी कि बीच में गैप दिखाई दे रहा है. हॉरिजॉन्टल मैट्रेस की बात करते हैं तो बीच में तो अपने को कुछ भी नहीं दिख रहा है. आइडियली जो सिंपल सूचर होता, सिंपल सूचर वुड हैव बीन लाइक दिस एंड वी वुड हैव सीन अ नॉट. यहाँ पे इधर भी बना के देख सकते हैं. सिंपल सूचर वुड हैव बीन लाइक दिस एंड देयर वुड हैव बीन अ नॉट लाइक दिस. Okay beta. Then there were questions related to other subjects, like pheochromocytoma question was there, I guess. Yes guys, what was the answer? कोई बात नहीं बेटा. अच्छा, उस क्वेश्चन का आंसर, बिकॉज ही वॉज आस्किंग अबाउट अ सिंपल इंटरप्टेड, सो उस क्वेश्चन में जो आंसर था दैट वाज सिंपल इंटरप्टेड. इसका कृष्णा इज सेइंग नॉट वाज ऑन द लेफ्ट साइड. हाँ, ये तो डायरेक्ट था. ठीक है बेटा. सो वी गो अहेड विद दिस. This was also a question which was, though it was a core anesthesia question, just sharing the overlapping questions. Yes, so you are correct about this. Then there was another question, something like this. This was again a core anatomy type of question. Foreign body impacted at the level of fourth thoracic vertebra. So the answer was arch of aorta. There was a question again. The answer here was okay, if unable to ventilate, then next step. Right, Dr. Deveki? Right. So this was a clear-cut question. Again, a radiology question. "40-year-old woman presents with complaint of fatigue, weight gain." This was also some medicine question, we can say. So this was a clear-cut case of thyroiditis, Hashimoto's, antithyroid peroxidase अच्छा, okay beta. ठीक है. So these were some of the questions which I was able to gather beta. I hope that probably somewhat related questions were there in the exam. They would not have been the exact questions, that is for sure, definitely. But anyways, you have done your best. Leave the rest on God. Let us all pray for all the lovely foreign medical graduates. May all of you pass. May all of you come out with flying colors, and you might be getting your results very soon. One thing which I would like to remind all the great doctors, the pattern of exam what we are seeing in the last few years, soon after the exam, we are not that confident that we have done really great because of a simple reason that we are not getting the same language of questions and the options in the exam what we are actually practicing before the exam. But because majority of the topics are definitely related somewhere here and there, which we have read, which we have prepared, which we have listened to the teachers, so definitely it was application of the knowledge which you have it here, and I am pretty confident that all the great doctors would have applied the knowledge in majority of the questions. So just wait for the results. I'm very positive about the results. Let's just hope and pray for all of you. Thank you, beta. Thank you very, very much. I may not be able to perform great all the time, beta, but I'll always keep trying my level best in whatever way I can. Thank you very much. Thank you, Dr. Debeki, beta. God bless you. Bye-bye.